Good morning and welcome on our next online meeting with experts organized by Medical Press in collaboration with key partners in public health. Today's meeting is titled Tobacco-Free Future, Is Europe and Poland on the Right Path? Today we celebrate World No Tobacco Day 2025 that was established by the World Health Organization, and its purpose is to draw attention to a common social problem, mostly smoking cigarettes and using nicotine products. It is also an opportunity to learn more about the harmful effects and health consequences of smoking tobacco. Despite global progress, tobacco use still causes around 700,000 deaths per year in the European Union. The burden of disease and cost of health system remain staggering. Today we will explore how various European Union countries, particularly Sweden, Czech Republic, and Poland, are navigating this public health challenge with special focus on health protection, mental health, and regulatory innovation. Topics of our discussion we will know in a few minutes. Let me introduce our experts panels. With really great pleasure and honor, welcome Professor Karl Fagerström from Sweden, as we all know, leading tobacco control researcher, founding member of the Society of Research, Non-Nicotine and Tobacco, deputy editor of the Nicotine and Tobacco Research. Welcome, Professor.
Thank you.
Let me welcome Professor Dominika Dudek, President of the Polish Psychiatric Society. Hello, Mr. President, Mrs. President, sorry.
Hello.
Hello. I also invite Mgr Jindřich Vobořil from Czech Republic, National Coordinator for Addictions. For many years, of course, he knew this all problems very good. Independent expert and chairman of the board of the Rational Addiction Policy think tank. Hello, Mr. Vobořil.
Hello, and I'm happy to share our experience.
We are waiting. And of course, I would like to welcome Dr. Jerzy Gryglewicz, public health expert, Lazarski University. Hello, Mr. Jerzy.
Hello.
And last but not least, Dr. Janusz Krupa, family physician from CMKP, Medical University of Warsaw, doctor with big experience working with patients. Hello, Mr. Janusz.
Hello, Mr. Kustosz. Hello, everybody.
It's a big day. We can call it like that because it's non-tobacco day. But as I start, it's different in countries in Europe. And today I'd like to hear from our experts how they gain the goal in each country, or how their path look to achieve the goals. So I would like to ask Professor Fagerström to tell us how it's possible, how Sweden did it, and is it the best path to do also in other countries?
Thank you very much. Can I have the first slide, please? So Sweden was not part of any of the two world wars where cigarettes were freely given out to the soldiers. So the Swedish men were not exposed to that. And sometime around the late 1960s and the beginning of the 1970s, the harmfulness of smoking started to become well known. And then we see the yellow line here, which is men that were using snus, was very low, but there were still snus use among, for example, farmers, miners, loggers, where simply cigarette smoking was very impractical, fishermen. And when smoking was realized to be harmful, cigarette smoking went down and snus use went up. We can then see the tobacco attributable mortality per 100,000 according to World Health Organization. And if we look for lung cancer, the average in the European Union is 220, for Sweden is 87. If we look at other cancers, for the European Union, it's 105, and for Sweden, 41. And for cardiovascular, the same 170, the average of the European Union, and 72 for the Swedish men. So the Swedish men are outliers when it comes to tobacco attributable death. Not the Swedish women, they are actually, if anything, above the EU average. But they have kept with their cigarette smoking up until more recently. So it was only the men that transferred from cigarettes. There are 3 countries in Europe where snus and similar products, talking about the new non-tobacco nicotine pouches, are used. It's Sweden, which has an exempt from the ban in the European Union, and the 2 countries, Norway and Iceland, which are not part of the EU. Look at tobacco attributable mortality again, this time a data set from Global Burden of Disease, 2021. We see Sweden has the lowest tobacco attributable death, followed by Norway and Iceland. The only 3 countries with significant snus use would all be in the position of first, second, and third. If it was to happen by random, it would be 1 out of 20,000 something. So this is a very significant and statistically certain finding. There is also a group in Sweden called the Snus Commission, and it has tried to figure out how many men in other European Union countries lives would have been saved if they would have had the same tobacco habits as the Swedish men. And for Poland, there would have been 46,000 men less per year. The Swedish government, this I just mentioned, we can go to the next slide. The current Swedish government is the very first government that has realized and admitted and bought into this harm reduction perspective. Usually governments have said that all tobacco products are equally harmful. Now the Secretary of Health has clearly endorsed the harm reduction perspective, and not only by lip service, but also so that they lower the tax on snus and increased it on cigarettes. And the price for a cigarette in Sweden is usually around 31 cents, while the snus bag 22 cents, and there is hardly no tax at all on the non-tobacco pouches, which cost usually around 18 cents. And the use of snus has also meant that Sweden is at what WHO talks about as endgame, that is 5% or less smokers. Sweden are at exactly 5% now. So I think there is some proof that harm reduction can operate. We see that in tobacco attributable death. We see that it can be done without costly governmental activities. The market forces can do this if there is a decent regulatory system so that the least harmful product is banned, like in the European Union, and the most harmful product is getting a red carpet. That's not the way to save lives and improve public health. And I think I stop there. Thank you very much.
Thank you very much, Professor. I think we'll come back to you also with some questions, during our debate, because today also I would like to invite you to ask questions each other to understand more your points of view and your experience. And I would like to ask Mr. Vobořil to present your experience and your path in Czech Republic.
Thank you. So this is the title of my presentation, so we can go to the next one. I'm sure this respected panel knows this very well, but for any audience that would listen to it from your podcast here, this is the basics knowledge of what's happening to our brain when we use addictive substances. What I want to say actually that the reward system in our brain is necessary. Without reward system and without our inclination to addictions, we would not exist. But of course, the situation can get sometimes out of the hands, as we know it, for example, with tobacco. But I want to stress the third sentence, and I read it: the same reward system also governs natural drives like reproduction, general food intake, etc. So I think it's quite important to put the addiction problem in the context of our usual everyday behavior. So this is how it works in the brain, and you have on left side you can see the dopamine pathways, on the right side the serotonin pathways. These are the things that happen when we want to have pleasure, when we want to satisfy our reward system, which I said is a very natural and necessary system for our survival. But at the same time, the same things sits on, let's say, pathological addictions or addictions that bring us more harms than the rewards itself. So here is my theory of cake. I made it up during my talk in Vienna, so I can call it Sacher cake theory. I'm asking always the audience: is cake or any dessert a necessary type of food? Can we do without it? And people, of course, answer yes. We can not only do without it; it would be better without it. Do we eat cakes when we are hungry? No, we eat cakes as a pleasure thing. So this is how any kind of addiction actually work. And so when we look at the politics and how we form policies, we have to make this pay attention to that this is actual natural, and it's not possible to get rid of it. So therefore we say addiction policy must focus on rather risk minimization than abstinence itself. We say abstinence is part of the solution, but not the only option, because it's not realistic. So that's why we try to define the Czech policy as in terms of regulating based on risks, not based on the legality and tradition, and that includes any kind of substance, including nicotine products and tobacco. This is our situation. So when we look at the problem size of addictions, so of course you see Czech Republic. Sorry, I know Poland is heart of Europe as well. So this is for Kazakhstan. So we can argue with the Czech Republic is heart of Europe. Of course, it's both. But anyway, so similar to Poland, you can see the tobacco is a big problem because of the size. We have an estimation of 15,000 premature deaths because of tobacco smoking every year. But of course, following by alcohol and other addictions, the illicit addictions are much smaller actually comparing to tobacco. So we must pay attention to tobacco. And then we said the current government program says, I'm not going to read the whole sentence, but we say that apart from needing to put money in the system of help, we want to regulate according to the risks. And we talk about the whole policy, whether it is alcohol, gambling, whether it is illicit drugs currently, or new psychomodulatory modulatory drugs. I will touch it one slide later, or tobacco. And we say there are, of course, always two. This is an EMCDDA chart, which says there are always two extremes. One is totally unregulated market, and the other one is also unregulated black market. So we try to find in our policy something in between, regulations that would minimize the harms and risk. So this is the Czech action plan approved by 2023. It's written by my office, but of course negotiated in the whole government. When we say minimizing harms and risks of both licit and illicit substances and products, because it includes digital addictions and gambling, is actually the overall policy. So it's not only strategies that we bring substitutions, exchange needles in order to avoid HIV, etc. But it's what we said, what I said above. It touches legislation, it touches things like taxation, it touches supporting different products on the market, supporting substituted market with lower risk products. So in that term, it's not only the type of service or type of intervention, but it's an overall policy, because abstinence is only part, not the only it's part, not the only option. Because that doesn't seem realistic. Similar to what Mr. Professor before me said, okay, we switch the market. It's not that we switch the addiction, we switch to lesser risk. So we say, okay, these are the key aspects of some kind of working policy. It has to be evidence-based. So difficult to put what is evidence today, because you have two big fighting industries, big pharma and big tobacco fighting which evidence is the right one, etc., etc., etc. So, but we say it has to be realistic and coordinated, defined financial and health approach. Let's go next slide. These are the 5 priorities. I don't want to bore you with the whole thing, but one thing that is new in our action plan that is going to finish this year, it's not only looking at the prevention and treatment as the main priority, but also if you look at the third one here, is tax collection. Yes, because this is a big thing in the whole policy. Once people start switching from cigarettes to alternatives, how do we tax the alternatives? Do we tax them the same as cigarettes, or do we support it with lower taxes? Now we have enormous growth in the whole Europe of illicit tobacco and counterfeit tobacco. So we are all losing a lot of money in our government budgets. And sometimes instead of health, the tax is the priority, and that's our big fight. Yes, we say, okay, let's support alternatives, but they say, okay, well, 10% of tobacco smokers switched, and where do we get the money from? So I think this is also important, and what I'm arguing is well, we should look rather at the taxing more the less risky products. We should rather look at the growing problem of counterfeit tobacco. The Olaf and other Europol and other institutions in the European Union say that it's about 10 billion euros that we are losing every year now on counterfeit tobacco in European Union, and each country billions of, in Czech Republic, crowns, zlotys, etc. There is also another example that I want to mention, that it's not only tobacco, it's our overall policy. We said, okay, we have all kind of new products all the time on the market. And now we have food, we have medicines, and now we have new products, for example, kratom, which is now big in European Union. which WHO said it doesn't. It's not. So there is also another example that I want to mention, that it's not only tobacco; it's our overall policy. We said, okay, we have all kind of new products all the time on the market, and now we have food, we have medicines. And now we have new products, for example, kratom, which is now big in European Union, which WHO said it doesn't, it's not as risky that we have to ban it, but we see that there are some risks attached. So we said, okay, let's regulate even those substances according to the risks, and we created a new category where we, through some process, put certain substances on very strictly regulated market, stricter than tobacco. All the things that we want with tobacco, such as plain packaging and specialized shops and specialized licenses, we have it here with substances such as kratom. So this is our kind of overall view in Czech policy. So EU debate on tobacco policy. Next slide, please. So we are in the situation in European Union where we say, okay, we have a beating cancer plan. By 2040, we want to be only 5% of people smoking. The only country that can reach it is Sweden, no one else, as we heard. Why? Because of the substitution harm reduction policy. I especially want to underline the word substitution harm reduction policy. We have medical substitutions to tobacco, but they're not that users friendly. So people want to switch to something that is kind of more users friendly rather than the pharma products, which should be some kind of a lesson for the pharma products to look at the tobacco, how they do it. Because the big tobacco managed, as well as Swedish Match managed, starting switching people from the smoking combustible to non-combustible, which is the biggest problem. So I don't think we can manage unless we support substituted market, let's say, meaning minimizing harms by switching to lower risk. Yes, this is again beating cancer plan and all the plans, but what actually works out of all these ideas is what Sweden showed. Of course, we can argue that Sweden in general is much stricter with all substances, but in this policy is actually very different to other areas. And it worked. And it worked not because of the government, with all my regards to Swedish government in many ways. It's because of the users. Users wanted it. Users are not as unclever as we think. And when there are substitution on the market, they prefer it. So that's why we say harm reduction is the only realistic in Czech policy. It's only realistic policy. The debate in the EU is going the other direction, banning the alternatives, and we argue don't push us to stop what we started doing and started proving being effective. As we have the proof, very concrete proof from Sweden, when the less than 5% people smoking, it started, the same situation started in Czech Republic, and we are quite afraid that the European debate is going the opposite direction. And this is our basics. We want minimizing harms as the main policy, regulating products according to their risks. And what we say, okay, if we have missing data, as the arguments are there, yes, then let's put money in the data and let's find solutions and find such substitutions that will be more and more safer. So this is what happened. I'll be very quick. In Czech Republic, we started switching. Finally, started switching. We until recently, Czech Republic was the country with the highest underage smoking. 11% smoking every day. Highest alcohol underage drinking. If you look at the study of ESPAT, where we look at 16-year-old. Sweden is coordinating this study every 4 years for several decades. We used to be the worst. Alcohol drinking, smoking, and finally the epidemic started calming down and it started, but yes, people switching to e-cigarettes, to nicotine pouches. These are the numbers, how it's happening finally. So as we say, Sweden, number one, that's an example that we should study, we should take into consideration. Sweden is very moderate in this debate. They don't want to kind of, with all my respect, as we say in Czech language, stick the nose up, yes? But I think it's quite important because if we can save lives, then we must save lives. Not that we can, we must. So again, you can see the drop, and I don't want to just. I would just echo. So let's go next slide. So what came out of this model? Yes, we need to speak about adolescence. This is one of the. So we should look a little bit comprehensively. One thing is adult smokers switching, and another thing is the newcomers. So that's one big area that we don't have much time to discuss it. And another thing is just simply alternative nicotine products should be regulated in terms of toxicity. So we can look at the levels and we should regulate it. And it means including taxation, including maybe advertising. So we have high certainty of evidence that it works. We didn't evidence of serious harms, but we still keep hearing different kind of claims that it's worse than cigarettes, whatever, nicotine pouches, worse than cigarettes. I heard the health commissioner in European Parliament saying that we have an evidence of e-cigarettes creating popcorn lungs, and that's a fake news. That's not only wrong information, it's a fake news. Yes, we know that it happened in few cases when the homemade e-cigarettes put with E-vitamin and cannabis oil, then that probably happened to few people. And it's dangerous, of course, if you do homemade, but nothing like proof of e-cigarettes bringing popcorn lungs. This is misleading, and that's even in the European Parliament preached. I think this is really need to be serious about evidence. So I think I will not go to every data that I'm sure people can study that. Let's go next slide. So what are the conclusions? Promoting rational addiction policy based on scientific evidence is the must. And if there is no scientific evidence, we have to put the money in. We are rich enough to study. Preventing and reducing health, social and economic harms is recommended as the overall policy approach. Use substitution effects, pricing strategy to create a substitution market with risky products is another solution. We know it from all across different fields in addiction, whether it is alcohol, whether it is gambling, and we have data of decades in this. We know that substitutions substitute each other. I can tell you one example of heroin disappearing from Czech Republic because the market is substituted with lower risk substance or buprenorphine. And as I said, let's put money in research. Because without money in research, the rhetorics of we don't have enough data, which I hear almost a decade now, is I think it's from a position that I worked in for so many years as a national drug coordinator who was responsible for policy in the whole country. Hearing we don't have data and we don't put money in finding data, it's very irresponsible from policy makers. So I think this is a rhetoric we should forget. We should put the data, and the data should be geared on finding less risky products, because total abstinence is for some people, not for all. And then be aware of growing illicit market, because the illicit market is such and I think Poland would understand it very much as much as Sweden or Czech Republic. These days, the money flowing from the illicit markets of tens of billions of euros to global organized crime attached to authoritarian governments. And you all know which governments are involved in big organized crime. So this is even bigger threat than the health threats here, because it's funding not only global terrorism, but also certain very unfriendly governments, including the money laundering from those illicit market. So this is something that we must not forget in the whole thing. Yes, and it's bigger and bigger. Well, we have information from the Frontex and Europol that last 5 years we had about 100 new counterfeit factories of producing counterfeit tobacco. So my final statement is, if there is 1% of chance that the policy of harm reduction may save lives of several million people, and we do not invest money in the research directly into looking at the possibilities, then it's a very irresponsible excuse. I don't see any reason why not put in any money and claiming we don't have enough data. I think we need to put money in data as countries and as European Union. I think this is my last slide, I guess.
Thank you very much, Mr. Vobořil. I'm really impressed with your presentation. I think we are all impressed because also when we hear about Sweden, lots of time we think, okay, Sweden, let's say it's really far away from Poland, different culture, different background, different products. So it's hard to compare to Poland. But when we can hear that it's possible to do it in a Czech way, let's call it like that, and it's a bigger picture than only, let's say, one solution. It's not only strategy. It's a really big change of how to think about public health and consequences. It's a really long path for Poland, I think, to find this way. And the question is, will we find this way? I would like to move now. Thank you again for your presentation. And I think we will come back to you and to Professor Fagerström with questions. Yeah. But now I would like to ask Dr. Janusz Krupa, before I will move to Professor Dominika Dudek. But first, Dr. Janusz Krupa, how it looks in Poland? Where is Poland in the context of smoking control now, today?
Okay. Unfortunately, I do not have good news for Poland or for Polish society. Over the couple of last years, the percentage of people smoking is increasing. So unfortunately, we go against what happens in other countries in Europe. In Poland, the prevalence of smoking is growing. So that's the first very good news. Secondly, my takeaway from all the discussions today, but not only today, because for the last year I spent several times my time in the parliament discussions and also in some round tables. In Poland, we have a little bit outdated approach to smoking cessation, which is smoker must quit and that's it. All right. So maybe it's a good approach, but we have only 3 full-scale anti-smoking outpatient clinics in Poland that are really professionally organized and that can support people in quitting smoking. So 3 anti-nicotine, clinics for 8 million smoking people. There is also the free helpline for smokers, which is called TPPP. It's a very good idea. However, the number of annual calls to this helpline is between 6,000 and 9,000 calls per year in a country where 8 million people smoke every day. The problem is also that those smokers, because of course they smoke on their own, but they also harm people around. And it's estimated that around 4 million Polish children, they are passive smokers every day. So I dare say that our very strict approach in Poland, that we need only to push on the smokers to totally quit smoking, is not working in our country. And as a practitioner, because I'm typical practitioner, I spend my life, sitting in the surgery, in the outpatient clinic, and I talk to many patients. So first of all, majority of them just don't want to quit. They don't see any reason because they say, okay, I have some conditions, so maybe it's too late. The other ones, they say, I don't want to quit because I'm still young. I don't see any consequences of quitting. So I think that also the awareness of the people that still smoke is pretty low in our country. So I'm afraid that if we go this way for the next couple of years, unfortunately, we will witness the death of many, many thousand people that could benefit from other approaches. In medicine, the hardest endpoint of any clinical trial is the death of the patient, yes? And I believe that as the doctors, as the physicians, or also as a society, we should do everything to decrease the number of deaths from smoking. Every year, around 70 to 80,000 people in Poland die because of the smoking. 70 to 80,000 people die of this. So if they switch to any other alternative that is much harmful and can give them a chance, to survive, I think would be a good approach, but it's not very, let's say, popular in Poland. So thank you very much for those 2 opinions from Sweden and from Czech Republic, because as Redactor Kustosz mentioned, these are 2 completely different countries, but applying, very similar approach, they were able, to substantially decrease the number of smokers. So congratulations to both countries, and I guess, or I wish.
Very much. So, at Polish Society of Psychiatrists, how it looks from your perspective, because we know smoking addiction. You have your own idea as a city how to with this, how we can deal with this in Poland. And the second question will be also about what are the risks of excluding mental health patients from tobacco control strategies.
So we have that beautiful goal to achieve 5% of smokers in the near future. But I think that unfortunately in Poland, this goal is completely unrealistic. And I must say that since 1990s, there has been a downward trend in the percentage of smokers in Poland. However, unfortunately, in 2017, this trend slowed down, and during the pandemic, it reversed. And currently, it is estimated that about 29% of Poles And of course, Polish tobacco and nicotine regulations face several challenges that may limit their effectiveness in reducing the number of smokers. And the previous speaker that traditionally we concentrate on the full abstinence, and of course it would be a beautiful goal, but also very unrealistic. And not all societies, not all people want to introduce this harm reducing strategies. What problems do I see in Poland? Lack of comprehensive support for addicted problems. Enforcement we use for the treatment of the addiction. Another problem is high social acceptance of this addiction. Another problem is created by e-cigarettes when young people start nicotine, they become very severely addicted very quickly. Also, it is very easy initiation by children. They use such nicotine-free flavored e-cigarettes. So, of course, if they are nicotine-free, we cannot talk about the addiction to nicotine. But the further addiction to cigarettes is not only addiction to nicotine, of course, it's pharmacological, pharmacodynamic action, but also the very important component is behavioral addiction. The behavior of taking cigarette and smoking. And one more problem is very poor education in schools. Now it's horrible because we are going to have health education in schools, but we are seeing protests against this health education. And what is striking for me, it's protest by church. Why? It's health education, which includes also education about such hazards like addictions, like nicotine addiction. So your second question was about mental health, and of course ignoring mental health also is one of barrier to achieve abstinence or harm reduction. First of all, patients with psychiatric disorders are often very strongly addicted to nicotine, particularly individuals with schizophrenia, depression, bipolar disorder, or some anxiety disorders. And subjectively, smoking improves their well-being by reducing, for example, negative symptoms in patients with schizophrenia, or improving to some extent cognitive functions. So as patients subjectively feel better when they smoke, it makes the treatment of this addiction extremely difficult for many patients. Moreover, when they try to quit smoking, they experience abstinence symptoms that include irritability, low mood, depressive mood, or anxiety. And they feel like it is a recurrence of the illness, not necessarily. But as I told you, this make the treatment much more difficult. And as I have already mentioned, tobacco addiction is not just physical, it's often deeply tied to psychological and behavioral patterns. So these patterns are also very strong and very important for our patients with mental disorders. And one other aspect is that if individuals who rely on smoking for emotional relief are forced to quit without mental health interventions, they may turn to other harmful coping mechanisms such as excessive alcohol consumption or drug use. So smoking may be like the first step to other addictions. Moreover, the rate of smokers among people who are addicted to alcohol is extremely high. Our routine psychiatric treatment does not include programs of nicotine and smoking cessation. If we ask about smoking, rather it is in the context of pharmacotherapy, because some medication we use as antipsychotics or antidepressants are in interactions with the smoking, with the amount of cigarettes that patients smoke. So we ask about that, but rather in the context of drug interactions, then as the goal to treat this addiction.
I'm still thinking how it's possible that when Czech Republic implement this program. Like, how did you do it? Really, I know that you show us a slides, you tell us, but is it? You think it's what is it different, and what will be your recommendation for Poland? Yeah, because I think it is most important for us to learn from you.
Of course, I don't feel we should teach Poland because we are on the very beginning of the way as well. But yes, I think we are in the center of Europe, very similar history, language, so we share a lot. Well, what happened actually in Czech Republic? You might be, some of you, for example, Professor Dudek might be informed that we had in the 80s and beginning of 90s and the end of 70s actually. Professor Dr. Docent Scala, who was like a creator of the addiction policy, that time I think quite modern addiction policy in the 80s, who was in charge of advising the governments how to look at addiction policies overly. And after him, us, his children, let's say, continue. So the addiction policy has always been from the beginning of 90s in charge of people who were looking at health objectives as a priority rather than repression or rather than prohibition or regulations, let's say. So help and public health was kind of always priority. And of course, in the beginning of the 90s, where the iron wall fall and the communism collapsed, the totalitarian system collapsed, we had an explosion of issues. But of course, the country was broken economically. So there were some of the colleagues from psychology and psychiatry field working in the government on the basics of minimal kind of help. And at that time, it was clear that in terms of new heroin problem arriving, methamphetamine problem growing, we said we don't have enough money rather than invest in harm reduction, because it was the cheapest way. And realistically, was the only option at the time, and it worked. It worked in many ways, as you might know, that less than 1% of people, injecting drug users are HIV positive. So almost no HIV among injecting drug users. And of course, we learned that substitution strategy in drugs worked in such way that not only people switched from heroin or other drugs to substituted substances, but also we learned that many of those people who went to maintenance actually at the end abstained, even though the primary goal was just a substitution. So so that was kind of a basic of strong believing in our government, all governments that came after, in like public health rather than only restrictions. So and then I was 2010 established as a national coordinator. I came from this field as well, and then I started integrating policies, gambling and alcohol. So we started studying, and we had this long government study called PAT, which look at the different kind of policies, and again it supported harm reduction as one of the major pillars. So since the very beginning, when we started establishing some policies, we had harm reduction, the 4 pillars. Recently, looking at the whole situation, as Professor Dudek, for example, said, it would be wonderful to have everybody abstinent, but that's not achievable goal. And again, we're not such a rich country to think that we can put money in something that doesn't work. So we should let's study what else is actually working. And again, we see substituted market, because substances substitute each other in many ways, and even not on substances. So you might have experienced people in treatment of heroin or methamphetamine start abstaining, but they come later, few years later, with alcohol problem or gambling problem. And of course, if you look at people who have gambling problem or alcohol problem, as mentioned previously, they smoke more, etc., etc. So these things interconnect, and of course, mental health and mental discomfort, not only mental health, serious problem of mental discomfort is also one of the triggers. So this is not abstinence cannot be the only goal. It can be part of it. And so the new government and the previous government already started going this path, and the new government said, okay, let's concentrate on regulating according to the risk, and let's study. Though there is many interests, and we can put it nicely on the paper, but you have, of course, all kind of industries thinking different, and of all kind of people inside of the government, civil service, not accepting that approach. So it's not easy. We are at the very, very beginning of it. But I think for us, very important, and that Czech mentality is very individualistic as well. Yes, and if voters, people want something, so then we kind of give in, and we see that it's a wish of people. People started switching, users started switching, and we promoted a lot, and we allowed advertising for pharma products, but it didn't work. But then the big tobacco came with other products, and it worked better. So we would like to encourage the pharma companies to make it more friendly, users friendly. But at the same time, we have to learn from it. I don't know if I'm answering your question, actually.
I think we are in the beginning, I can say. So for your examples and your experience, it's for us a lot. Hopefully we will be able to talk with you more. I think Dr. Krupa also had a question before you leave us. Yes?
It will be a very short question. how did you work with medical societies? Because usually practitioners, or let's say key opinion leaders from the medical field, like cardiologists, pulmonologists, they are strongly against all these alternatives in smoking, yeah, or to normal smoking. How did you work with these societies, and what kind of data did you show to these societies that they probably supported you?
Of course, we have big battle inside. I run an organization, just 400 employees. Number of them are medical doctors. We also run GP clinics and psychiatric clinics and infectology. We also have a very strong figure among us who is quite renowned, Dr. Mravchik, who is a quite renowned epidemiologist, and he was for many years head of the National Monitoring Center. And I think this is quite important. The National Monitoring Center, when we integrated policies, and we said we cannot separate addiction policies, and we have to look at one issue, whether it's illicit or licit drugs, the monitoring center started collecting data every year and putting it on the government table, because it's a government body, on tobacco, on gambling, on digital addictions, on alcohol, and on other substances, whether it is old, let's say, illicit drugs or new coming drugs, which might be illicit, but at this moment are in the shadow zone. So, and based on this data, which we have, every year, so we can see the trends, and led by very strong figure, Dr. Mravchik, he's an epidemiologist who was a head of this monitoring center for more than 20 years. Based on that, the debate can be kind of more realistic. Otherwise, you are very right. That we have a debate with Respiratory Society or Pneumological Society, and we find that the data they present are not solid enough, and it's kind of at some point I had to say it loud, and I had to say, listen, this rhetorics that supporting alternatives to cigarettes are only support tobacco companies is very false and not right arguments, because now I don't know if you can hear me, if it's not interrupted. You have two industries, both have products and fight against each other, which is big tobacco and big pharma. And the big pharma is claiming that their products are good, and they don't call it harm reduction, but what is it? If it's substitution, then it's harm reduction, and the other ones is not. So because it's not a pharmacological product, but basically it's a battle between two industries, and this is what I politically put on the table. We cannot listen to none of those industries, none of those two industries, and the people who are connected to those industries should not be considered as people who should have any strong say, whether it is from big tobacco or the big pharma, because they both fight for their own products. So I think this is quite important to put it on a political table, and I think soon it will blow up. Yeah? This kind of debate. And in the next COP, I'll be there as a national expert. We want to see that in the Geneva debate, the same as we ask in the tobacco industry should not have a say, the pharma industry should not have say either, because they are in big conflict of interests. So I think this when you take this away, all of a sudden you have an option of realistic debate. And finally, what I'm saying, okay, if we find out that some of the products are not good enough, then we should study in finding better products. This is the and as we support pharma products, we should support any kind of product that substitutes market of the most harmful cigarettes. Does it make sense what I'm trying to say?
Thank you.
It's
Thank
all
you very
complex,
much.
Science.
Yes, I think it's very bold, if I can say, in Poland. In Poland, it's really hard to get into this round table, really, to with open-minded and talk about. Maybe last small question, because when I'm listening to you, I think because in Poland now we have elections, and one of our candidates took, we don't know where it's nicotine bag or snus, probably nicotine bag. And there's a big conversation. What did he do? What did he do on air? Is it good or not? But my question is, if I don't want to judge what this person did, but I would like to ask you about this, for example, nicotine bags, and question what is follow with this topic. Is it because some people are saying that if, for example, it's with flavor, it's not good because it can push your habit further, and it shouldn't be something nice to help you, let's say, to use other harmful products. What is your view on this?
Yeah, of course it's a complex question, especially when you have flavors that are kind of close to children's taste. Yes. So it's a very complex issue, but we argue for years. We've been arguing that anything that helps people smoking and stop using tar, which is the 80% of the problem, should be considered. So flavor debate is big debate, and we say some of the flavors should remain, maybe not all. But again, it's a big debate. We don't have full agreement internally in the government, but so far, the debate of my colleagues and kind of my camp is stronger in terms of arguments. I think we have enough arguments to show that it actually works. So anything that supports, that's why the problem comes with the pharma products, because the pharma products were not geared to users. They were medicines, and people didn't want it. So that's a clear example how we should not go forward. So now some of the pharma products are better. For example, sprays. People like the sprays better than the chewing gums that didn't work. The plasters that didn't work, because as I'm sure Professor Dudek or anybody from my field would support that it's not only about flavors, it's also about rituals. It's not only about nicotine itself. The rituals are very important in the whole thing, and if I can replace it with other rituals, other flavors, because I give some benefit to that, then it's a good way forward. And of course, we need to keep studying. We need to keep watching it closely. So we cannot say, okay, that's good, so let's do it. We have to keep studying it. But for example, my argument about underage smoking, I'm saying if I see that 11% of our 16-year-olds smoking every day, and in 10 years I will have only 5% of smoking and 6% of using alternatives, then even in the underage, it's harm reduction. We don't support sell to underage. We want to be very strict on climbing on everybody who sells to underage, but it still happens. So, but if I have 11% of smoking in 10 years and another 6% of people vaping, then it's a failed policy.
Okay, thank you, Mr. Vobořil. Thank you for your experience and your time. Hope you will would like to ask you again in some time, because we need more time to discuss. So have a good day and see you again hopefully soon. I would like to, because also Professor Dudek. Yes, sorry.
I just said thank you for inviting me to this. I said thank you for inviting me to this respective panel.
Thank you very much. All the best. Bye.
Bye.
So I would like to now to give voice to Professor Dudek, because Professor also would have to leave to next thing in a planned day. So Professor Dudek, please, if you can sum up and share also your activities as a Polish Society of Psychiatrists.
Yes, thank you very much. Before I tell that, very short comment to the previous speaker, because the problem of addiction among young people is very important. If they start to be addicted earlier, their addiction usually is very strong, very difficult to treat, and it will be their lifestyle for the whole life, probably. And nicotine abuse paves way to the other addictions. And one thing, what we should do with young people is not only education at school that I have already mentioned, but also we should somehow control social media, because it is the field that really is very difficult to control and unfortunately also may illegally promote nicotine and smoking. But coming back to the activity of Polish Psychiatric Association, I am very proud that we really started to discuss this problem. First, last year, we published such a paper, our recommendation, what to do with nicotine addiction and tobacco smoking and cigarette smoking among patients with psychiatric disorders. As I was also talking, it is a very difficult problem. And in our recommendation, we understand very well that in this population, the full abstinence is unrealistic goal. So we think that harm reduction is a reasonable way reasonable strategy to reduce smoking, and we hope that it may be the first step to complete smoking cessation. So it was one document last year, and this year Polish Psychiatric Association submitted a draft of national strategy for reduction tobacco smoking and nicotine products use to the Prime Minister's office. And in this strategy, we included many modern solutions, such as the development of a network of anti-nicotine counseling centers, reimbursement for medications used in the treatment, mandatory standardization and testing of all nicotine products before they are approved for sale, and many other solutions. And we believe that coordinated cooperation between various ministries is very important. That's why we sent this draft to the Prime Minister's office, because we think that leaving this issue solely to the Ministry of Health is a mistake. Because inter-ministerial efforts should also include other ministries, such as Ministry of Finance, Ministry of Education, Ministry of Digitalization, and even Ministry of Agriculture. We also suggest that the European Anti-Tobacco Directive should be revised to include a ban on flavor additives in e-cigarettes that appeal to children, similar to regulations for tobacco products, like, for example, menthol cigarettes have been banned. But still, there are very easily achievable candy-like cigarettes that attract kids. And also, one more postulate of Polish Psychiatric Association, as I strongly believe that coordination of actions between various ministries is crucial. That would be important to create a post for interministerial coordinator for public health who would work for Polish government, and I think it would be very, very beneficial. That's what we did, and now we wait for the answer from the part of the government. And I think that the problem of smoking and addiction is so important in Poland. I remind you that it's 29% of people who smoke, and high percentage among young people. So I hope that the government will do something with that.
Thank you a lot, Professor Dudek. Thank you for your time, especially because it's a really long debate, and I think we still can get to this debate 1, 2, 3 days more. So hopefully we'll continue in the nearest future. And thank you for being now also a part in a table with your voice as a psychiatrist society, which is, I think, very important when we are talking about addiction, which is smoking. So thank you very much, Professor, and see you next time. Thank you. I would like to now to ask Dr. Jerzy Gryglewicz, like I asked before, about Polish system. Is Polish system ready, or what should be changed that our system will be ready, for example, for changes like in Sweden or in Czech?
Ja bym chciał powiedzieć, że między innymi te wszystkie problemy są zapisane w strategii, o której bardzo krótko pani profesor powiedziała. W tej chwili wszelkie działania, jeśli chodzi o zmniejszenie dopalenia, opierają się w zasadzie wyłącznie na działaniach fiskalnych, a wszelkie nowelizacje ustawy antytytoniowej dotyczą wyłącznie kwestii finansowych, zwłaszcza akcyzy, ewentualnie elementów związanych z wykluczeniem danych wyrobów tytoniowych na danym terenie. To, co jest najbardziej istotne w tej strategii, tutaj Polskie Towarzystwo Psychiatryczne zaprezentowało pewne kluczowe elementy, to po pierwsze stworzenie odpowiedniej liczby poradni leczenia uzależnień. W tej chwili mamy tylko 3 oficjalne poradnie telefoniczne, które próbują poprawić dostęp do leczenia uzależnień. Bardzo ważnym elementem są kwestie finansowe. Polska jest państwem na tle innych państw, który wydaje bardzo mało na leczenie psychiatryczne i leczenie uzależnień, bo to jest jeden jak gdyby obszar finansowy w NFZ-cie. Wydajemy zaledwie 3% wydatków na ochronę zdrowia, na kwestie związane właśnie z uzależnieniami i leczeniem psychiatrycznym. To jest w stosunku do innych państw niewielka kwota. To, co jest ogromnym problemem, to jest to, że w tej chwili mamy kilka instytucji, które jak gdyby w niewielkim stopniu zajmują się polityką antynikotynową, czyli Ministerstwo Zdrowia, Krajowe Centrum Przeciwdziałania Uzależnieniom oraz Narodowy Instytut Zdrowia Publicznego. To rozproszenie decyzyjności w tym zakresie powoduje pewien chaos i praktycznie w naszym kraju nic się nie dzieje. Trzeba mieć nadzieję, że ta inicjatywa Polskiego Towarzystwa Zdrowia Psychicznego może spowodować to, że pójdziemy o krok do przodu i wszystkie te aspekty, które między innymi w Czeskiej Republice zostały wdrożone, u nas też uda się zrealizować.
Thank you very much, Dr. Gryglewicz. Just one more thing. In your opinion, what should happen in Poland that we can change it? I mean, we heard about Czech Republic, and what we can do in Poland to change it? Like, do you think that it's possible that people will be on the same table from like out of big pharma, like Mr. Vobořil said, and with no tobacco industry? Is it even possible, and who should start it?
To jest możliwe tylko w jednym przypadku, kiedy inicjatywa wyjdzie ze strony regulatora, czyli Ministerstwa Zdrowia. W tej chwili Ministerstwo Zdrowia nie zgłasza takiej koncepcji, żeby zająć się polityką antytytoniową w całości. Są tylko wybiórcze działania. Nie mamy działań ukierunkowanych na edukację dzieci i młodzieży. Brak jest jakiejkolwiek współpracy ze środowiskiem medycznym, ale także również z przemysłem, czy to tytoniowym, czy farmaceutycznym w tym zakresie. Czyli brak jest jakiegokolwiek dialogu, a to powoduje tylko wyłącznie to, że nie posuwamy się do przodu i przede wszystkim nie osiągamy konkretnych celów, które powinny być zapisane właśnie w strategii ogólnopolskiej, bo tylko wtedy jesteśmy w stanie osiągnąć jakieś konkretne rozwiązania i konkretne sukcesy.
Okay. Thank you very much, Dr. Gryglewicz. I would like now ask Dr. Janusz Krupa, because we should, I think, end it slowly, our debate, because on the end I will ask Professor Fagerström his point of view and his opinion about how and what we should change in Poland. So, Dr. Janusz Krupa, do you as a physician now have any tools to support patients that are tobacco users and nicotine users?
Of course. First of all, we are all obliged to ask patients if they smoke or not. First of all, so we do it. Secondly, if they do smoke, we should provide them very short intervention. Yes, 5P intervention. We should ask and advise, etc., etc. So we try to do it. One of the good solutions is so-called coordinated care in POZ, in a primary care. And this is a very good concept because it gives us a chance to spend half an hour with a patient once a year to discuss strategically about the health of this person. Yeah? So personally, I use this time to talk with patients and to advise them or ask them, to quit smoking. And last but not least, there is a completely new program, Moje Zdrowie, My Health, that was initiated just 3 weeks ago. And this is very, very big program. It's addressed to all Polish citizens above 20 years old. So all people above 20 years, they can apply. They can submit their questionnaire to their primary care physician, and they will get additional consultation one of the points of this consultation is also talking about smoking and smoking cessation. So we do have some tools, but again, I'm afraid that primary care physicians, if we will be left alone, will not be able, to carry this very difficult task. But definitely, we have over the time we have more and more tools, and we do our best, to address this issue. But again, we need also some support from the politicians. We also need support from journalists, from media. Please support us, to make smoking not that fancy anymore. Thank you.
Thank you very much, Dr. Krupa. So, Professor Karl Fagerström, you started, and if you can finish it, what is Yes, thank you very much. What is your opinion when you hear all the experts today, and also your big experience? I think the biggest experience in Poland in the tobacco-free country. What are your thoughts and recommendations for Poland? Because this is our today main goal of our debate. Yes.
Right. Thank you very much. A couple of things. First, World Health Organization has installed the so-called end game of 5% or less smoking. I don't think we should have a prevalence goal as being the target here. 5% of Poles smoking. That is 2 million Poles smoking. That is far too much. Rather, we should have a goal of close to no tobacco attributable disease. Like with caffeine, I don't care how many are using caffeine as long as it is not that very harmful. The problem with the new and less harmful products, that is that people are usually very afraid of adolescents starting to use them. And Dr. Vobořil gave a very good example there that we cannot find a good product that there will be zero use among adolescents. But as we do have regulatory system for adolescents and alcohol, the same system should be installed for nicotine products. And this is a matter for the country, the state to regulate and rule in as much as possible and be sure that also the rules and laws are lived as they are enacted. I think in order, also Dr. Vobořil mentioned about the pleasure of engaging the dopamine and other systems in the brain, and the cigarette is really the carrot here. When we come with a plea to go abstinence, to stop entirely, and maybe with the help of patches or gum, which helps a little bit, but not that very much, that is the whip. In Sweden, we have also had carrots, the snus, and now the new nicotine pouches, and we also have electronic cigarettes. But since we have a tradition with snus in Sweden, electronic cigarettes has not been very much used. So what I would like to see in Poland, that is rein in the room for cigarettes. For example, it was mentioned generic packaging, make them more less possible for advertising, increase the tax, decrease the availability, and or even, I would go so far as to say, Singapore and New Zealand were very close to phase out cigarettes. And by phasing out, the system was that from the start of the law, you had to be, for example, 18 years to buy cigarettes. Next year, you had to be 19. The year thereafter, you need to be 20 to buy cigarettes. And when you are up at 25 years to buy cigarettes, no one really would buy because very few starts after the age of 25 years. So a phasing out system like that would not ask anyone to give up. It simply stops the influx of new cigarette smokers. And this would work even better if there were carrots available. And banning, as the European Union might do, and some individual countries already have done, yes, you can do that in the parliament. You can vote and you can have a ban. But that doesn't mean that the products you are banning disappear from the Polish country or any other country. Rather, there will be bad products that are not followed any regulatory regimes and in the hands of the organized crime and less tax income for the state. I think that is all. Thank you.
Thank you a lot, Professor Fagerström. Thank you for today's meeting. Thank you for debate. I think when we sum up, we have lots of interesting points that we can use in Poland. And hopefully we will meet, like I said before, again, and maybe with some good information that we were able in Poland to do the next step into tobacco-free country. So thank you a lot, Professor Karl Fagerström. Thank you a lot, of course, Professor Dominika Dudek. Thank you, Dr. Jerzy Gryglewicz. Thank you, Dr. Janusz Krupa, and thank you, Mgr Jindřich Vobořil from Czech. So I wish you all good evening, good day, good weekend, and choose wisely. Thank you, and see you soon.
Thank you very much. Thank you. Goodbye.
Bye.